In this oral presentation in English, I will present the clinical condition of a patient with a lower limb amputation and the specific characteristic of this disability. Finally, I will present my intervention on a patient during a climbing program. Here is the plan of this presentation that we are going to see in detail. Amputation is the surgical or traumatic removal of one end of the body. The choice of amputation is planned and thought through. In some cases, it is carried out urgently when the patient's prognosis is vital. Consequently, endovascular revascularization has nowadays become the first choice of treatment. Thus, amputation is often linked to unsuccessful attempts at revascularization. The purpose of removing a limb or part of a limb is to alleviate gangrene and other wound infection, where the body is locally deprived of blood circulation. In French, epidemiological data concerning the prevalence of amputees is uncommon and sometimes old. In 2007, according to the report by the French National Authority for Health, there were 90,000 amputees and approximately 8,300 new cases per year. Of these individuals, 95% had a lower limb amputated. According to Behrens and al., the associated diseases that we find in the majority of Western countries are vascular impairment, of which 50% of patients are diabetic, infection, trauma, congenital malformation, and tumor. The percentages are quite variable according to the economic situation of the country. Each pathology presents a risk factors that may or may not to be modifiable. Numerous studies carried out on subjects who have undergone lower limb amputation have revealed that age, sex, and heredity are among the risk factors that are considered non-modifiable. In addition, sedentary lifestyle, diet, lifestyle habits, smoking, diabetes, dyslipidemia, high blood pressure, obesity, coronary and cerebrovascular disease are modifiable risk factors. Possible complications and symptoms can appear in the post-operative phase. 6 complications are quite common and have been studied at length. They include pain, mainly felt due to a poor adaptation of the sleeve of the prosthesis or due to the threatening spicules. The perception of so-called ghostly sensation resulting in a cerebral reorganization of the body schema, contractions, hematomas, which are risk factors in cases such as falls on the amputated limb, deep or superficial infections, and wound dehiscence. The choice of the level of amputation has a direct impact on the patient's autonomy. Moreover, the probability of an orthopedic device and a functional rehabilitation prescription depends on the preservation of the joint during the amputation. This plays a major role in the functional outcomes of the individual. The cut during the operation is either proximal or distal. Distal amputation is the most desirable choice in order to ensure better autonomy and less psychological consequences. The types of amputations are very heterogeneous, the designations are common. It's from the above-mentioned characteristics that a prosthesis is created adapted to the stump and the patient's lifestyle. This meticulous work is carried out by the orthopedist. The prosthesis is a material that has evolved over time. Today, plastic is used for temporary prostheses. Glass composite prostheses are mainly used with a conventional suspension systems. Finally, carbon or titanium prostheses are mainly used by amputee sportsmen and women or by a minority of non-athletes due to their price. Lower limb amputation also creates biomechanical disturbances in walking. Indeed, the article by Eskenazi specifies that this audience undertakes slow walking. In addition, the loss of normal eccentric muscular functions of control and concentric propulsion in the foot and ankle have an impact on walking. Also, there is a reduction in the angle of knee flexion and a deterioration in the inclination and rotation of the pelvis. Finally, lower limb amputation often leads to muscle weakness, amyotrophy, of the amputated limb, which has consequences on stability and postural control. Consequently, the patient will implement a gain strategy by compensatory support between the healthy limb and the impacted limb. The presence of articular and muscle deficits is therefore an extremely limiting factor in the resumption of walking by the amputee patient with an appliance and thus run counter to the compensation usually used to allow efficient walking. Thus, amputation will lead to biomechanical and neurosensory changes which will disrupt the postural control mechanism. In addition, to ensure better balance, the patient increases visual control to compensate for the loss of muscles, joints, and skin space. Finally, amputation can generate anxiety and also a psychological shock that impacts on the individual's thought. However, this characteristic will not to be discussed. Here, I will present the subject on which I spoke in the context of a federal practice, which is a climbing for a public with a lower limb amputation. I intervened with a young 15 years old teenager, amputated at the transtibial level on the left side following a road accident during a bicycle ride. Since February 2020, the patient has been following climbing courses with the French Climbing Federation in relation with the French Handisport Federation. I define objectives in relation to the patient's initial capacities following an initial observation session and the setting up of a free session without objectives to let the young teenager explore the difficulties that climbing can create. I found that he had a beginner's level with fairly good qualities. So it seemed interesting to me to develop his lower limb propulsion and to develop homolateral coordination by adjusting his postural control while improving his muscle strength in his forearms. In order to establish a program to improve its balance, I have chosen to set up situations with the following objectives: to improve the distribution of bipodal support and develop unipodal balance on the amputated lower limb, to develop anaerobic lactic capacity, to develop muscle strength in the forearms, to develop information taking, reading the path, reading the holds, anticipation, taking feedback into account, to control feelings and psychological slackening. I have decided to present three sessions which do not follow that will allow you to understand the construction of the program. Situation 1 is proposed to allow this young person to decentralize his vision with his hands. This will therefore induce in him a less jerky climbing, a focus on his lower limbs, and a dynamic intention to push while growing using the tip of his right foot and his prosthesis on the left side, thus limiting the number of hand holds helps to improve information acquisition and to anticipate movements. Situation 2 is a continuation of the previous situation. However, I decided to design a session on the boulder by setting up obstacles in order to progressively develop a climbing profile through the learning of techniques. Similarly, this situation leads this teenager to build various solutions in order to enrich his gestural repertoire. In situation 3, through the slalom, the patient will have to accept the course and find solutions which will allow him to move without being unbalanced. Techniques will be taught so that he can reach one of these three slaloms. The evaluation has not to be set up, but it can enable the patient to obtain information about his abilities and resources. The evaluation grid, including the climbing criteria, is based on the model of biomechanical, energetic, informational, and emotional resources. The educator will take into account the length of the cycle and the progression of the adolescent. The grid can be modified if the score is too low in order to take the individual's resources seriously. This specific grading is based on the school model.